There we go. Okay, there we go.
I'm going to ask all of the participants to mute themselves just so we make sure that the recording doesn't have any background noise on it. So how are you doing?
I'm doing okay. I feel like I'm juggling. So it's a good thing my hormones are balanced because my energy's good.
Good. Well, you're always juggling something. So we're really happy to have you here. And
sorry, I was a little bit late. Sorry about that.
That's okay. No worries. We just are happy to have your expertise so that you can share it with our group members. So we have people who know nothing about hormones, and we have some people who know a lot about hormones. And I got a lot of good questions. So
Okay.
what I thought we would do is just jump right in. So for those of you who don't know Dr. Berkson, she is, I'm not going to read your whole bio because.
Oh yeah, don't do that. Let's just do the Q&A.
No, well, I want people to know how extensive your background is in functional medicine. So she was one of the mothers of functional medicine and has been practicing in this area forever. And if you don't know what functional medicine, tell us what that is. I have an idea, but I'm not 100% sure. And she is a whole lot of fun. I got to meet her in person a couple of months ago at a symposium. And I will go ahead and tell you that she is 74 years old. So this is
I'm going to be 73 in a month and a half.
Oh, 73. Okay. I don't know where I got 74. So anyway, this is what hormones can do for you, just so you know. Okay. So I have a couple of my own questions, and then we'll get to the elephant in the room. So I would like to hear why some women can't tolerate any form of progesterone, no matter how it's dosed. And this is actually Rena's question, so I should let her ask it. But I run into this quite a bit, and so I don't really understand it from my own perspective, and I'd like Rena to get an answer to her question.
There's several different reasons that you could be what we call hyperreactive to progesterone. So, and one of the reasons that I am so involved in hormones is I did my first rotation in integrative medicine with Jonathan Wright in 1977, and he was into hormones then and said they're foundational. So you can't do functional medicine without evaluating hormones. So he opened up Meridian Laboratory the next year, and I've been running 24-hour urine since 1978 when he opened the laboratory. And then when I wrote Hormone Deception, I got invited to be a distinguished scholar at an estrogen think tank at Tulane University, where I worked with the two scientists who discovered the first receptor, Elwa Jensen, and the scientists that discovered the second receptor, Yanaki Gustafson and Ken Korek. So I got to talk a lot with gentlemen who discovered the receptor. That's how hormones work. And there's a lot about not handling hormones well if the receptor functionality is not healthy. So there's all these layers we think of. When you want hormones, you think, well, I'll go to a doctor and I'll get tested. And if I'm low, I'll get some. And if I'm high, I'll avoid some. And we kind of think just measuring it and then repleting it is the whole story. But the story is the receptor functionality from the gentleman that discovered the receptor. And these receptors can be malfunctioning because of a number of reasons. So first of all, you can have progesterone resistance. This is a concept that was first discovered in women who had been survivors of breast cancer, where they measured progesterone in them and then measured different parameters that show that your progesterone is working. For example, in the luteal phase, your breast should get warmer. And these women, the breasts did not get warmer. And they introduced the term progesterone resistance, just like you can have thyroid resistance, you can have insulin resistance, you can have resistance to any hormone because that receptor is not functional. So you can have women who respond adversely to progesterone, either because they have progesterone resistance, which means they have endocrine disrupting pollutants that are competitively inhibiting. So you have to rule out if there are competitive inhibitors, they need to be detoxed. And the receptor is a bowl. It's a bowl. It's like a or a malleable purse made out of fine Italian leather. It's very malleable because it's these signals of life. So when estrogen swims on in, or thyroid or progesterone, it's got to be filled with nutrients that pull that hormone in and allow it to shimmy in space and genomically deliver its signal to the gene. So that means the receptor needs to have zinc, B6, magnesium, vitamin A, iodine, all of those. And if they're not in adequate form, then you can have an adverse reaction to a hormone. So there's this tapestry of hormones. It's not just giving someone hormones. One, is the receptor available? And it could be not. And two, does the receptor have all the transcriptional factors, which are these nutrients? Now, one of the other ways it can be competitively inhibited that's common in today's society is that you have elevated cortisol. Cortisol is the one hormone that you can't live without. You can live with low levels of thyroid and feel badly. You can live with low levels of estrogen and feel badly. You can't live with low levels of cortisol. There's that old House movie episode where there's this big CEO and he goes catatonic, and they're all the doctors at the chalkboard trying to figure out what's wrong with them, and nobody can figure it out. So they're going to let the wife just wheel the CEO who's catatonic out the hospital doors, and House comes up with the idea at the last minute to save the day that it's cortisol that's missing, because you can't live without cortisol. So he runs down with a syringe of cortisol and he jams it in through the guy's jeans, and he slowly wakes up, because that's the truth of cortisol. So receptors have a higher affinity for cortisol than any other hormone. And there's a lot of promiscuity or slutty behavior between the receptors of the nuclear family. So estrogen can sit on male hormone receptors, and male hormones can sit on estrogen receptors, but cortisol can be the bully and sit on everybody's receptors. So you could have an adverse reaction to progesterone because the cortisol is abnormal. And then the one other answer to that is that you can have a reaction to a hormone just like you can have an adverse reaction to food. And we think of most allergies, the classic ones, is driven by immunoglobulin E, and that's where you have a classic allergic response. But we think of food allergies as more immunoglobulin G and M, where they're delayed. But you can have the same reactivities to hormones. So especially with high-risk people now, I do hormone desensitization, testing and desensitization if needed, like you would with an allergy. And the way that you can do that, since I did my first rotation with Dr. Wright, as I said, in 1977, his office offers a long distance energetic testing of hormones, and then a 2-week series of sublingual drops if you become reactive. So that's my number one go-to after making sure that the receptors are clear, that cortisol is healthy, that nutrients that allow the receptor to receive the hormone are all present. Then now with all my breast cancer patients, all the people who say I've had a history of not handling progesterone, I send them to Virginia, and I can give you that email. She'll do this for anyone, which is a long distance with saliva testing and then desensitizing. And then you can also use NAET. Dr. David Brownstein, who's my big buddy and brother-like friend, he has someone in his office that uses that. It's an allergy way of acupressure points that can help someone's body start handling some kind of constituent that they had an adverse reaction to. So the number one reason is that your receptors aren't able to receive progesterone. So there's progesterone resistance. And the other one is that you have promiscuity or excess of other hormones or pollutants, or you don't have enough nutrients, or you have reactivity to the hormone itself. Anyone comes in and says, I don't handle progesterone well, it's a good idea to test all the hormones. So when I send a patient to Virginia, I do estrone, estriol, estradiol, cortisol, DHEA, testosterone, and progesterone. And then the one last way you could be reactive to progesterone, and by the way, that program, which takes about a few weeks to do, the majority of people who say that they were reactive to progesterone, with taking a look at all this, are no longer reactive. You get them over it. The one other thing is progesterone is actually made throughout the body, but it's mostly made in the corpus luteum after ovulation, mostly, but it's made in other areas, like it's made in the brain, it's made in the heart and the nervous system, but it's mostly made in women in the ovaries. And at the same time that it's made in the ovaries, so is oxytocin. Because oxytocin is along for the ride. If the woman's going to get pregnant, it wants to be kind of shut up during the pregnancy and then be active at the end for contraction for the pregnancy to happen. So once in a blue moon, I found that to get someone over progesterone issues, they needed to have a 1-month course of a little oxytocin, because progesterone and oxytocin are both produced together and they both help each other work. And I just know this now from being in hormones for so long. I don't know how many people know that when the corpus luteum makes progesterone, it also makes a little oxytocin. So being that I've been using oxytocin in practice and lecturing on it at PCCA, started to try that. So in a few women, giving oxytocin nasal spray for a month helped them get over progesterone. So it's always good to have a bunch of tools in your tool bag, because when someone says this will help you get over progesterone, and then you have a patient and you try it and it doesn't work, what's tool number
Right.
2, right? So
Right.
those are some, is that helpful? I can't
Rena,
hear
do you have any?
Yes, that is very helpful. And if you can point me to any information, that's great. I don't want to take up too much time on it, but I just saw an NAT practitioner last week because it was recommended. I might have read it on your site. I know I read one of your sites, some information from you a while back. So
Well, I've been wanting to take that myself so that I know how to do it, because right now I send it all out to Virginia and it's fabulous, but I send that out to her and I would like to be able to do that myself. I think you can go online and there's online courses to become an NAET practitioner and they cost about $2,500.
Wow, not bad. Yeah, so I just saw an acupuncturist and she's been doing it for 12 years or something. So
see, that would be great. So you could send a patient that it has problems with progesterone to her, but then if that didn't work, these are the other things that you think of. And whenever I start hormones now, I always think of detoxing the receptors, making sure that they have all the nutrients. Those are transcriptional factors. So zinc, vitamin A, B6, magnesium, iodine, all of those are necessary.
Right.
Vitamin A is not a very trendy vitamin, but vitamin A is is a major transcriptional factor for all hormones. So I have actually 2 new products coming out with biotics in December. And
Yeah,
what
I was
they
going to
do,
ask about that.
the first product cleans off the receptors, and the second product gives the transcriptional factors, and it also gives you a high dose PABA and boron that keep your hormones level and zen throughout the day. So I had designed Metagenics' first femline when Metagenics first opened in 1982. And that was a really big seller for a long time. And I've taken what I learned from formulating that line, and now I've come out, it's not out yet, it's almost out with biotics. And those 2 products will help you do exactly what I'm saying to help the hormones work better, but they won't do the desensitization if you need that.
So can you, I mean, and I know you can talk about this all day, but
I have a big mouth. Yeah.
this is a topic that comes up very commonly. I have a free group too that's got 8,800 members in it. And this comes up all the time. You know, when we start talking about estrogen, the first thing that somebody posts is, oh, I can't take estrogen because I'm high risk, or estrogen causes cancer. So can you talk about where that myth came from, and how do you advocate for yourself with a physician whose viewpoint is firmly entrenched in that myth?
Okay, that is a great question. I just wanted to look, there was a chat here. Oh, okay, that was from Rena, so we got that. That is the best question, because the standard of care and the standard thought is that estrogen drives breast cancer, and that you really should be very careful. You mention estrogen to women and they cover their breasts in a protective motion. So let's understand, let's take this apart, as they say in Hollywood and theater. Let's take this apart. So first of all, before 2002, there were approximately 20 million women in America on hormone replacement. It was considered the way to protect yourself as you were older. So everybody was on it. And the two most common prescriptions were Premarin, which is estrogen from horse urine, conjugated equine estrogen. And then there was a combination product of that horse estrogen with a synthetic form of progesterone. A synthetic form of progesterone is called progestin. That was medroxyprogesterone acetate. That combo, two hormones in one, was called Prempro. So Premarin and Prempro were what most women were on in the United States, millions of women, and they were told if they were on it, they would be feminine forever. And it would prevent aging, slow it down, and prevent heart disease. So up until then, the NIH, we are an aging nation. We have more people who are getting older than we have people getting younger. And in a very short period of time, the people who are going to be geriatric way outweigh any young people. So we are an aging nation. So the NIH realized this, and they didn't want to topple Medicare. So they took 40 prestigious institutions and they said, women live longer than men. Let's look at women every which way and see if we can figure out how to keep them younger, longer, and out of Medicare so we don't topple it. And so they looked at women from a wide range, what works for their bones, how does sitting affect their hormones. But one of the biggest things they did is they did the first ever large randomized trial on this horse estrogen or this combo product. And they had this was called the Women's Health Initiative Hormone Arm studies. And it was stopped prematurely in July of 2002 because they thought they discovered to their shock that hormone replacement was causing cancer, causing heart disease, causing the very things that they were telling women it would protect against. And American doctors stopped prescribing. Wyeth was sued by women who developed breast cancer after being on one of these hormones. And you never know if somebody's going to develop cancer, and you never know if they had a quiet breast cancer where they suddenly had it grow, but they were successfully sued for billions of dollars. So there became this litigious cloud over doctors prescribing. And in Europe, doctors didn't stop prescribing. In Europe, they mostly use estradiol, a molecular form that's exactly like the most powerful estrogen in our body, or they use a form of the pregnancy estrogen called estriol. And they didn't throw the baby out with the bathwater with prescriptions due to the American Women's Health Initiative. So Leon Spiroff wrote the book that pretty much most OB/GYN docs learn in med school. He is considered the professor at Oregon, the father of gynecology. He started writing within a few months of the Women's Health Initiative that his analysis was it was a statistical fiasco and they had it all wrong. And it looked like the estrogen only arm was protecting breasts. And he started writing on it. He said, don't let scary headlines sell. We've had years of clinical experience that women that go on estrogen fare better. Don't let this one study, but the headline news, the scary headline news that hormone replacement causes breast cancer and heart disease and dementia. It was like it was bad. And the question became, why would Mother Nature make the very hormone that drives Homo sapiens? Why would she make that cancer causing? Why would she make that stroke causing? I just had this very interesting conversation with Abraham Morgenthaler. I lectured with him in Miami a few months ago, and he's the Harvard urologist that his whole life is sharing that testosterone lessens the risk of aggressive prostate cancer. And if you stay on it with prostate cancer, you have less risk of dying from the prostate cancer or recurrence. So he's the same battle of men as we've been having with women. But since 2002, most American doctors stopped prescribing. There was this idea that Wyeth had been so successfully sued, they could be sued and lose their license too. And women started to think of estrogen as driving breast cancer. So behind the scenes, many people were reanalyzing all this. I spent 3 years writing a book called Safe Hormone, Smart Women, because I was so upset because I realized that the literature showed that estrogen actually protects breast tissue, that testosterone protects breast tissue, that you're more protected if you're on hormones than not. So I went on this march and I wrote a whole book going over all of the data. Now, fast forward to December 13th, 2019 in San Antonio. Every year in San Antonio, there's a breast cancer symposium. And the researchers from wonderful institutions, we have so many smart people in our country. So researchers get together once a year and share their data on breast cancer. So December 13th, 2019, 13 prestigious cancer institutions reanalyzed the Women's Health Initiative together under a man who presented it named Chabowski. And so it was Brigham Young from Harvard, Fred Hutchinson Research Center, MD Anderson, Stanford. It was all the biggies. And it was called the 19-year reanalysis of the Women's Health Initiative. And they said exactly what started to be shown just within months of it, but didn't make headline news. They said, if a woman is on estrogen, and it could even be Premarin, the horse estrogen, for a short period of time, and you track it out over 19 years, because that's when their reanalysis ended, she had a 29% decreased case incidence of getting breast cancer. It protected her against getting breast cancer in a healthy woman. If she did get breast cancer and she'd been on Premarin, now I'm not talking about the combo product, but just the horse estrogen, she had a decreased incidence of dying from breast cancer. That's called a decreased fatality incidence by 44%. Nothing has ever in pharmacology decreased our risk if you get breast cancer of dying from it by almost 50%. They said this protection might go on even more, but the reanalysis stopped at 19 years. So all of these prestigious cancer societies under Chabowski, who started to publish in 2018, part of why there was a statistical fiasco in the Women's Health Initiative, and I'll get to that in a minute. They said in a healthy woman, taking estrogen protects you against getting breast cancer, even if you take it for 2-3 years, especially within the 10-year window of menopause. And if you've been on some estrogen for 2-3 years plus or longer, and then you get breast cancer, you have a much better chance of not dying from it. It's huge. That did not make headline news. When that first came out, that came out in December 13th. I was lecturing in Vegas for PCCA's huge hormone conference, and nobody there had heard this data at all at that time.
But if you get breast cancer, the first thing your doctor is going to do is take you off the estrogen.
The standard of care right now doesn't match the science. And part of that is because of the litigious success of women suing, and that makes everybody frightened. And it's become non-standard of care. And what is standard of care? If a doctor's not practicing standard of care, then they can be sued. I went out on a date last night, of all things. I'm still dating, God forbid if you're still dating your 70s. I have lots of tales to tell. And I went out with this gentleman who is the lawyer for the Texas Medical Board of all things. And all he does is look at standard of care. We had this 2.5-hour conversation about standard of care. It was so interesting. It's become a way, if a doctor isn't doing standard of care, that you can be sued. So that's made women and doctors all step back from estrogen. When the truth of it is that estrogen does so many more protective things, not just your breast. So the Women's Health Initiative came out in July, it was July 9th, 2002. And then in October, the Cache County studies came out, and they got lost completely in these scary, nasty headlines of estrogen. And what they showed, so that was a group of scientists looking at almost 10,000 people in Cache County, Utah. They were healthy people in their 50s who didn't have cognitive decline, and they watched them prospectively as they moved into the future. And if they were on hormones, if women had been on estrogen for at least 10 years, she had a decreased incidence of getting Alzheimer's disease by 50%. Like nothing protects your brain like estrogen, but that got all lost because it was published only a few months after the scary headlines and the not accurate headlines. Once it's been reanalyzed, those headlines were not accurate. But that's never left the cultural consciousness. Fear gets into the cultural consciousness, and it's very hard to remove that blanket of perception, which is part of what I try and do. I had breast cancer 30 years ago. My mother took diethylstilbestrol when she was pregnant with me by injection and an oral pill. And when I was young, I had many cancers. And I had to learn how to turn that around. But I've now been on hormone replacement for almost 25 years, which is not standard of care. So I care a lot about high-risk women and the standard of care and what's happening. So I just lectured where Ann was with me August 13th at Asheville, North Carolina, talking on giving hormone replacement to breast cancer patients, not just healthy women. And there's 25 plus studies where they've tracked women from 2.5 years to 26 years of giving women hormones right after they finish their treatment for breast cancer. There's no study that shows they fared any worse from matched cohort at all. And there's a number of studies that show that they had less recurrence, less death if they did have recurrence, and a much higher quality of life, especially cognition, because where your memories are consolidated and stored, your hippocampus, the volume of that is the whole deal of staying with a great brain as you age, and hormones rule that volume. That's why my last book was called Sexy Brain, because sex steroid hormones really help keep your brain healthy. And aging, if you had to make a recipe, is a loss of hormones plus inflammation. So if you can give hormones and eat and live in a lifestyle that minimizes inflammation, you push morbidity to a further distance out and you stay better and younger longer. So the science isn't matching the standard of care, but it's starting to happen, especially around testosterone. There's more and more human studies, some case reports and some small trials where they give testosterone to women right after they had breast cancer, because cancer is growth out of control. And testosterone is a growth controller, especially at the breast. So there's a woman, a physician named Glazer, who's even using testosterone pellets around the areas where the tumors were in the breast. So that is the most well-accepted hormone to be given to breast cancer patients right now. And I actually have a little book that I put together called Hormones for Breast Cancer Survivors, that is a compilation of the research up to that time that you could hand to your doctor to help them see this. So I put this together for women to hand to the doctors, and often invite the doctors to give me a call because I'd like to talk to them, because they're scared to give women hormones because they think it's going to further their breast cancer, when in actuality, we're thinking now that what really drives breast cancer are cells called tumor initiating cells or breast cancer stem cells, and they don't have receptors. Once again, that receptor for estrogen to go into, they're not driven by estrogen. So slowly but surely, the causation of breast cancer and the role of hormones is being turned on its head, but the standard of care hasn't quite caught up. But if you have some research to show the doctor, and you can sign a release saying, I'll take total responsibility and won't sue you if something happens to me, that's only fair. Then what you can do is, there more and more doctors are signing up to not only give hormones, but to give hormones to high-risk women. I hope that wasn't too long of an answer.
I say take them this book.
And Safe Hormone Smart Women, my other book.
Safe Home. So can you talk a little bit about the long-term benefits of estrogen and progesterone? I mean, you've touched on that some.
It's a great question. There is nothing in your world that will help keep you healthier or younger than hormone replacement. Exercise is great, but it's not as powerful as hormones. Food, quality diet, avoiding ultra-processed foods, that's fantastic, but it's not as powerful as hormones. You do those things actually so receptors stay healthier, so your hormones will work. And they're out of vogue. They're not taught in med school. I have a good girlfriend in town who graduated first in her class. She's an internist and she's never run an estradiol level in her practice ever. And I look at her and go, I don't know how you practice. And she looks at me and she doesn't know. But she just, every doctor I have just keeps saying, you're the healthiest breast cancer patient we have. No one that's in their mid 70s talks or looks like you. And so there's a disconnect. Because part of what's doing that, it's not the only thing, but part of what's doing that is having hormones on board. Just like you have, if I can't see, I have the technology to wear glasses. If we age and have less hormones, we have the technology to replace them, but we have to get them in the right amount. That's really an important level. And if you were on hormones, you don't need as much blood pressure medicine. Your blood sugar stays better. I open up my book, Save Hormones, Smart Women, with a quote from Dr. Salpeter, where she says, we would have 50% less cases of type 2 diabetes if women were put on hormones once they went into menopause. So hormones help keep the whole physiology younger, longer, but the biggest deal is the brain. Most people, when they get older, they start talking a little slower. They start searching for words. If you're going to be checking out at a checkout counter and there's an elderly person versus a younger person, usually the one that's older is going to be a much slower line than the younger, but not if you're on hormones and exercising and eating well and doing a lot of the other things. A famous conversation that puts this up for me is I worked for 6 years here in Austin at a clinic called the Wiseman Family Practice Clinic. And it was started by a gentleman, Richard Wiseman, who just retired a few years ago after 56 years in practice. And he was doing hormones for the last 40 years or so. And he was on testosterone for years. And he was this hunk in his mid 70s. I mean, he was doing Ironman and women would come in and have to fan themselves. He was so handsome. And he just was amazing. And a big part of it was hormone replacement for him, because this also is the same way for our lovely gentleman that we love so much. He said something I've never forgotten, and I call it my best water fountain conversation. He said, if you take 100 people who all got the memo to exercise and work out and eat well, and half of them were on hormone replacement that was tested and individually repleted for them, you could cherry pick out who was on hormones and who weren't on hormones, because you stand taller, your coloring is better, you speak, you don't get the little old lady voice, your vocal cords have a lot of receptors for hormones. In fact, so much so that you have to be very careful with singers about giving them testosterone, or you could change the vocal range that they could do. So that you have receptors for hormones on your eyes. They have a lot to do. You get more eye disease as you age because you have less hormones protecting your eyes. So you want hormones on board. We know now they're safer than ever before. You need to have someone that helps you do it. And when you eat well and exercise, you're supporting your hormones. So I don't know, is that helpful for you at all?
Yeah. So is it ever too late to start?
Great question. No, you can start hormones in your 90s. Your receptors have been shut down. You think of your receptors as flowers in a garden, because they receive from bees the signals, from hormones the signals, and they flourish and they make you flourish. But now the garden has died and it's all old and got weeds in it. That's how the receptors, they shut down, they down regulate. So when you start giving hormone, you have to gently open up those receptors, or they become hyperactive for about a year. So there's a slower process of giving hormones, and you have to make sure there's no heart disease. If there's any heart disease, you have to just do a few things to make sure that it's being addressed in the older woman who's getting hormones. And the other thing that you want to make sure is tracking the two things in the blood, the sex hormone binding globulin and the follicle stimulating FSH, the follicle stimulating hormone. When you're on a really good hormone program for you, FSH should be really going down, and it should be going down to closer to premenopausal levels. That's part of the goal. And the more that happens, the more anti-aging happens. But you have to make sure that the binding proteins aren't elevating. And that's where the nuances of giving hormone replacement in a really good way go. But you literally can turn back the clock. So I'm going to give you a great patient. Had this patient in Tulsa, Oklahoma. I worked with Jerry Block. I'm not a medical doctor, but I train medical doctors. I've been into hormones, but I happen to not be a medical doctor. It was very interesting, fickle finger of fate of my career. So I often team up and work a lot with medical teams. So I was working with Jerry Block, and this woman came in. She was in her mid-90s, very isolated, very overweight, on 14, 15 medications, like an old woman, looked like an old woman. So Jerry discovered that she was on one med that make you gain weight, and he got her off that medicine. First, he put her on hormones very slowly. He got her digestion going so the receptor would be flush with all the nutrients. He did a 1 week little detox. We do that in older people, and now we do it in everybody just to clear off those receptors, and got her slowly on hormones. And he would track them with a hand DEXA scan to make sure that she had osteoporosis really bad, and that within 2-3 years, we reversed that. She had normal bone density in her 90s, but that took stomach acid and digestive support and other things like that. So she ended up losing a lot of weight, going down to 3 or 4 medications, and turning around socially, where she was no longer wanting to be isolated, but to be social. And this woman started to hang out a lot with the pool boy. And actually developed, I don't know the intimacy of it all, but a really profound relationship with this pool boy that came regularly to their home and became having an active life. So the kids sent a joint Christmas card to Dr. Block and myself and said, "Thank you so much for giving us our mother back. Thank you." And that's what hormones can do, but the typical doctor isn't comfy with that. That's not been standard of care for that. The memory of the litigious atmosphere is still there. So now is the time. Things are all going the other way, slowly, because we're at the beginning of it, but we're in an era now of understanding and appreciating hormones. And at the same time, the FDA is wanting to limit compounding pharmacists from the legality of making individualized bioidentical hormones. So that's, I don't know if we're going to get to that in this little conversation, but in the 60s, so I'm kind of a child of the 60s. And when the Beatles came back from the Maharishi, I went and lived in India for a while and learned Ayurvedic medicine and yoga and so forth. And I remember there was a play on Broadway called "This is the Dawning of the Age of Aquarius." So it's kind of like that now with hormones. This is the dawning of the age of the estrogen. We're learning that estrogen protects the breast. Estrogen protects the brain. Progesterone in particular protects the lungs. Progesterone and estrogen protect the gut wall. They upregulate adhesive proteins that prevent leaky gut. They upregulate occludin and junctional adhesive molecule A. They're like amazing. They're gut wall protectors. And of course, as you age, your biome ages and your gut wall ages. But if you have hormones on board, it's much more slowly. Nothing stops you from dying. I had one woman who was sure if she went on hormones, she should not be in menopause anymore. She would overcome biologically hardwired reproductive milestones. And I said, no, we still go through. She was mad at me. She felt I'd failed her as a practitioner because I didn't get her out of menopause. We can't undo nature's reproductive milestones, but what we can do is soften the blow of them. And the biggest deal is energy. Energy is money in the bank, right? If you have energy when you wake up and it's sustained, you don't have crashes where you have to lay on the couch. And if your mind is facile and you can think of something you want to do and you can do it and get it done, when you get older, you think of these things, but you don't have the mojo to get it done. You're overwhelmed more. All of that's coming from not enough hormones on board, and then the nutrients that help make it work, and that tapestry that we talked about. And I've seen this now, most of my friends are in their mid 70s and late 70s, the people I've been knowing for years. And the people that aren't on hormones and aren't exercising, they're the ones that are not wanting to practice anymore and are starting to wear muumuus. They're gaining a lot of weight. They have no muscle. Hormones help you maintain your muscle, especially testosterone. And the more you work out, you make more testosterone. Muscle helps you slow down aging too. Muscle is right up there with hormones, and they're intimately connected. We now have new research that came out this year showing that when you work out, when you do some weights, your muscles actually release little proteins that go to your eyes and your brain, and they clean everything up. So hormones and muscle mass and eating diverse foods and caretaking your biome, these are powerful tools to prevent depression, anxiety, overwhelm, and keep your brain really going strong. And energy and brain function, hormones on board are the biggest protectors, and diet and exercise intermingle with that.
So here's a little bit of a philosophical question that one of our people asked. She said, realistically, can we get access to HRT when we don't have health insurance? Because, you know, most doctors won't prescribe it. So that leads you to have to go see a functional physician or somebody who may not accept insurance. And so where's the least resistance to try to financially be able to work this out? Because not everybody has the resources to be able to, you know, drop a few $1,000s to get hormone care.
Most of this isn't covered by insurance. You know,
Right.
It is for men. It's this huge bias in medicine, especially around hormones. Like if we were to lose the right to have non-FDA bioidentical hormones, men have many FDA approved forms of testosterone.
Exactly.
Women have no FDA approved form of testosterone. We would have no more testosterone if that happens. Right now, there's no FDA approved testosterone. There is one FDA approved bioidentical hormone that just passed phase 3 trials about 11, 12 months ago. It's called Bijuve, and
Yep.
It's actually the company from the old CEOs of Prempro. So they used to put down bioidentical hormones, and then they saw the train is coming. This is the dawning of the age of Aquarius. So they saw that, and they designed an oral estradiol and micronized progesterone in 4 different dosages, and they took it through phase 1, 2, and 3. And that is now a company called Bijuve, and the FDA is trying to say Bijuve is FDA approved. It's bioidentical. This is what the bioidentical hormone should be, and it doesn't have any testosterone added to it. And that is part of the war, the struggle that's coming out, is that company versus the right of compounders to be able to have a doctor write in a script and get an individualized bioidentical compounded hormone.
Right. I mean, it's so frustrating.
So most hormones aren't covered by insurance for women. This Bijuve will, or estradiol patches, which have a place. I have an estradiol patch on right there right now. So I kind of merge it with some of my vaginal delivery. But hormones, pretty much if you're going to be on hormones, it's about an average of about $120 a month, I would think. And then you've got to go to somebody, you've got to be monitored. If you have a uterus within the first year, you really need a vaginal ultrasound just to check that thickening of the uterus called your endometrial stripe, just to make sure. I make everybody do that. I make everybody, before they go on hormones, have a baseline mammogram. You know, you want to do these things safely. Very few doctors do that. So I have a lot of women that we do a vaginal ultrasound. They've been on hormones for 5-6 years. It turns out their vaginal stripe is 2-3 times what it should be. We get a biopsy, there's no cancer there, but you know that they didn't have enough progesterone. So it is a bit of money to do this. You're going to have a vaginal ultrasound. You're going to have some testing. And on the average, most hormones cost about $130 a month right now, unless you were to go. And even if this with insurance, I think this for 3 months with insurance was $75. So that was, not a lot per month. But hormones are a family of hormones. You rarely just do estradiol. So the truth of it is, it's not a completely inexpensive venture. It isn't something that normally is covered by insurance. So it's not like most people don't get coverage, although I hear here and there, I meet a woman who is somehow getting coverage. I've never put my hormones in for coverage for my insurance, and I've been on them for 25 years. But I just keep working and just pray to God I can keep working and afford everything that I do. Because I like to do IV ozone and IVs, and I do a lot of things to try and stay well, and they all cost money. So I'm kind of the ilk where I just want to work harder. I don't have a husband. I make my own money, and I'm always, well, if it costs more, I'm going to make it. But for average person, it can be daunting. So this, one of the options is going to be Bijuve. Although you don't have estriol as part of it, and you don't have testosterone as part of it, but that is going to be insurance reimbursable. So is the estradiol patch. So there's little versions coming out, but it is not an inexpensive venture.
So I'd like in the last few minutes to open it up for people to ask you questions. I mean, I got these from the group, but I'd like to open it up in case anybody has had something that has come to mind while you've been talking.
And I hope
Terry.
this has been helpful to you.
So helpful.
Oh God, yes.
Okay.
I could listen to you all day.
Who's saying this?
That's
I,
Stephanie.
Oh, hi there, Stephanie.
I actually do sometimes listen to you all day on your podcasts.
Oh, you do?
I do. I had a transvaginal ultrasound last year after hormone replacement, and I looked at the tech and I said, "What's my stripe measurement?" And she looked at me like, "What?" And she said, "It's a 3." I said, "Great." And I only knew that because I heard you on a podcast talking about that.
That's well, you know, I just interviewed Dr. Angela DeRosa. You got to hear that interview. She was fantastic. It's so great because I don't sell anything. I'm not having the podcast to monetize it. I just like to have great people on and have great conversations. And I learned so much from the people I have on too. And her conversation about, she said that if she could get the FSH below 20, that she can take a lot of women off of blood pressure meds. That is the magic spot to get the FSH down below 20. So I haven't run my own FSH in a while, but Dr. Roberts just ran hers and she's 76 and her FSH is 7. So in a premenopausal woman, your FSH is really is 5 to 10. It's really low. And as you stop ovulating, it goes high. And part of one of the things you want to track with hormone replacement is that you're reversing your age biologically. And one of the markers is FSH. That's known by very few people. And then of course, to monitor your endometrial stripe to make sure you've got enough progesterone. I just had the most surrealistic experience. This woman is exactly the same age as me. We were born the same week. And she couldn't hear. So we had a Zoom meeting. I normally do meetings on phone. And she looked gray. She looked like a little old lady. She had a little old lady voice. And you think, oh my gosh, she's never been on hormones. But she was been on hormones for 20 years. And she said she'd been kayaking and exercising and eating a lot of veggies. And yet she looked like my mother. So when we dove into her history, she's had an endometrial stripe of 16 for years. And her gynecologist did biopsies and said, well, you know, you aren't malignant, so there's nothing to worry about. But she was not able to sleep and she was not having balanced hormones. But it is, people age in a very diverse manner. We age so differently. And what we want to do for ourselves and our patients is figure out the most important things for us to slow that aging process down so we don't end up on a pharmaceutical conveyor belt. You know, and each person, it's a little different. So for her, obviously, and her doctor kept elevating her oral progesterone. She was at 365 milligrams of oral progesterone before bed, and she had an endometrial stripe that was very large, meaning she didn't have enough progesterone. So oral progesterone does not work in everybody to protect the lining of the uterus. In many women, you need vaginal or topical. Yes, Anne?
So that brings up a question that I wanted to have you explain to everybody, the idea of using oral and topical together.
Okay, so oral progesterone we give to really make the neurosteroids progesterone, the neurosteroids, and I don't know why my brain is farting on that name of the main neurosteroid. Allopregnanolone. Yeah, there it is. For a second I had that. didn't take my hormones yet today. So anyway, allopregnenolone really helps. And then it's GABA, it signals the calming neurotransmitters of the brain. So we use oral progesterone to calm the nervous system and to help sleep. But there's been a number of studies where they took a look at the levels of progesterone when a patient takes it orally versus they take it IM, an injection, or they take it topically, or they take it vaginally. Like, so and also the thickness of the uterus. And it turned out that oral progesterone in many women doesn't increase the progesterone level in the breast or the uterus. And in some women it does. It's variable. But when you gave progesterone either on the skin topically or vaginally, you got the highest and most immediate elevation of progesterone in the local tissues of the breast and the uterus. So you might give an oral to help someone sleep, but then you might want to add another progesterone to protect the other tissues. So what I've ended up now, if someone has no trouble sleeping at all, then you don't recommend oral progesterone at night. There's no reason for that.
Who are those people?
I actually have a few
I want to meet
patients,
them.
like I have a PhD. She deals with first responders, and she's an ex-cancer patient, and she sleeps like a rock. She doesn't need any oral, but that's not a common experience. As we age, many of us have sleeping issues. And then if we get really old with dementia, we get sundowner syndrome, where we sleep all day and are awake at night. So somebody said once at a conference, insomnia is the way God killed you. But hormones help bring sleep back on board. Your progesterone and your estrogen have a lot to do with sleep. So one, oral progesterone helps you sleep, or two, if you're still breaking through with hot flashes and not sleeping well with that, it's your estrogen isn't of a good enough level, and you want to look at your FSH with that. But we can give, if someone has an elevated uterine stripe, an endometrial stripe, the best place to give progesterone is right vaginally, because it's going to go right into that area. And also topically will give you better tissue. So sometimes now we're starting to combine delivery modes at the same time. Like I've got my estriol. I guess that fell off. I'm pointing to it and it's not there anymore. Normally I'm wearing it on my arm, but it's not there. That's the problem with those patches, is they do fall off. I go to the gym a lot and I'm on all the machines, so they can fall off. So that's can be a little bit more expensive, but I used to give oral progesterone and then a biased cream. Now in the biased cream, I add progesterone also. So I give progesterone through a variety of delivery modes. Does that answer that?
Yeah. And what time constraints are we under? Because I want to be respectful of your time, but
I'm really fine. I'm really fine. I can hang out longer. If you guys can hang out longer, I can hang out longer.
Can you talk about the difference between estradiol and estriol, and when you would choose one over the other, or both, or?
Oh, that's a great question. So estradiol, there are people like Rouzier is a very famous lecturer in hormones, and he only recommends oral estradiol, and he says your body's going to make estriol from it, so I give it. But estriol is so important. It does so many things. You don't know how much. That's like a crapshoot. So in fact, Dr. Wright did a study. It was a small study. He did it on naturopathic students from Bastyr, and he measured their ratio of estrogens to each other in premenopausal women. Remember, with hormone replacement, you're wanting to, in some way, mimic premenopausal state. And he found that the highest estrogen was estriol, and that estriol is an anti-carcinogenic hormone. It is the one estrogen, 89 to 90% signals ER beta. So there's 12 known receptors for estrogen, but the first 3 are the most understood. So Elwood Jensen discovered ER alpha, that's the first one. And estradiol, and then the second one is ER beta. So it's alpha and beta. They're just going through is that the Greek alphabet or I think it's the Greek alphabet. It might be the Latin alphabet, I'm not sure.
It's Greek.
And then the third one is GPR. It's a transmembranous instantaneous receptor. The first two are, for the docs in here, ligand bound genomic, and the third one is non-genomic, and then we'll stop that. That's just a little aside. But Estradiol signals both the first and the second receptor. So some people say, why not just give estradiol? But you don't totally know when it's going to signal what. The second receptor, when it's signaled, protects against breast cancer. The first one promotes growth, promotes many things, but you want controlled growth. So you want equal signaling to A and B. So what's become the standard of care in functional medicine, really because of Jonathan Wright's work, who happened to be my first mentor and start Meridian Laboratory, is to give both A and B signalers together. So that's called biased, where you combine estradiol plus estriol. In the old days, when he first started doing it in the late 1970s, we did triest, and he gave estriol, estradiol, and estrone. Those three are the major parent estrogens, although there's 60 estrogenic molecules in the body. There's lots of them, because each, as it's broken down, you make all different types of metabolites. You have the parent hormones, estrone, estriol, estradiol. Then you have the daughters, the catechol-estrogens, and you have the granddaughters. So there's many estrogenic compounds. And when you look at all of those, you get even a deeper appreciation of how to balance somebody's hormones. But estradiol signals both receptors. Estriol signals mainly about 85% of the time the second receptor, which protects against cancer. So estriol is, we think of pregnancy as mainly being due to progesterone, and that's why it got its name, progest, to support gestation. Progesterone, it supports gestation. So that's thought of as a major pregnancy hormone, but estriol is really a huge pregnancy hormone. And one of the things it does is it protects the mother from being flushed with so many hormones and for her not to get ill. So it is a very protective estrogen. And when a mom is pregnant, she starts loosening up a lot to be able to give birth and pass the baby through the canal. So the gut wall starts to become leaky. Just from the process of being pregnant. Well, estriol is a big protector of the gut wall. So we could use this in many ways to protect an aging gut. And we even give estriol to inflammatory bowel disease patients, multiple sclerosis patients, to autoimmune patients, because it does upregulate so successfully an adhesive protein that keeps the one-celled gut wall, they're called enterocytes, tight together. So I like biased. In a healthy woman with no health problems, they've come to know that you give an 80-20 ratio. I kind of like to lean toward a 50-50, or you're dealing with somebody that has breast cancer, giving a lot more estriol. So I don't like to be bound to this 80-20, 50-50 all the time. I might go away from that. And that's just a ratio of those two estrogens together. Used to be triest, but estrone lost its popularity because it's an aggravating estrogen and it's more related to things that people think of as bad estrogen dominance. So that got dropped, the old triest. Biased came in. Not everybody agrees with it. Some people just give one of the estrogens. When you give two, it's called biased. Usually when I do give vaginal, I like vaginal delivery of hormones a lot. Any way that you take hormones after a few years, your body can start to reject taking them in that way. So some women that did great with topical will get dermal fatigue. And Meridian just called me up, Dr. Shea from Meridian just called me up a few weeks ago, and she said, we're having some women that have been taking hormones vaginally now for a few years, starting to get mucosal fatigue. So I have learned that if someone's on hormones for long periods of time, and hopefully we all will be, right? I hope to be the most hormonally balanced corpse in the crematorium, that you sometimes have to rotate your delivery modes or add different ones because of that building emerging fact that you can start to become resistant to a way that you took it. But the reason I like vaginal delivery, which not a lot of people do, most people do topical, is because I had breast cancer and I wanted to take hormones and I wanted to not get breast cancer again. And everyone was saying estrogen causes breast cancer. So I went on this sleuth to try and find out, well, what's the safest way to get hormones into me where I don't increase my risk of getting cancer again. Because once you have a cancer, you're somebody who could have another cancer more easily than someone who never had a cancer. So you always want to make your remission your mission. So there was a study that I bumped into that was published in ACOG, the Journal of, the American Gynecologists. And it was an extraordinary study that came out of Finland for this woman's PhD thesis. And Finland's a socialized country, so they have noticed that women on hormones have less dementia, less diabetes, less bone hip fractures. They do better. So they give all women for free hormones when they become menopausal. Any way they want them, they give them for free. That is the status quo at the moment in Finland. So this woman said, hey, we've got tumor registries. We have a breast cancer registry where everyone who has breast cancer goes into this registry. We have adverse cardiovascular event registries. We've got death registries. Why don't I monitor how women were taking hormones over time and see what happened to them for her PhD thesis? What a great study. So she tracked about 140,000 women over 14 years to see which way they took estrogen. It was only about estrogen. Which way they took estrogen, who got breast cancer, who didn't, who died, who had a heart attack or a stroke. And what she found is if women took hormones compared to women who were not on hormones, it's always the best research is always comparing someone on call it an experimental component to a group that are not taking it. So called a matched cohort, so to speak. So this was epidemiologic. It wasn't totally causal. It was observational, but still, she found that women who took hormones vaginally never had an increased risk of any adverse events at all, or women who only used estriol, because in Europe, some doctors just give estriol, but she found if they took topical estrogen, after 5 years, there was a slight increase in breast cancer. Now this goes against the 19-year reanalysis, but it's what she found. Or if they did estradiol in any way, there was a slight increased risk after 5 years if it was topical or oral. But if they got their hormones in vaginally, there was never any worse event than not. So I sent this article. I tried to reach this woman. I thought this article was extraordinary. She didn't ever, because sometimes they'll put the emails by the author's affiliation, and she never answered me. I tried calling her. I was very hyperbolic about my appreciation of this hard work that she did. But after that, I started taking my hormones vaginally, and I started tracking my blood with it. And I found that when I took it vaginally, the levels would peak about 5 hours and slowly go down. So I divide the dose in morning at night vaginally, and I was able to get the best results of my hormones once I started to do that. And I sent this research to Dr. Wright. He started giving all of his hormones vaginally. That was it based on that study. It was such an extraordinary study. Not everybody does this. David Rosensweet gives his delivery all topical with an oil. David Brownstein gives it all topical with creams. And there's different properties of the bases that you mix it with.
Right.
But based on that study, I've become a big fan of vaginal delivery. And the one thing that I've noticed, so I'm a DES daughter, so I have to get Pap smears every year because we have a much higher incidence of clear vaginal adenocarcinoma. And when I had a hysterectomy because of all my issues with DES, I saved my cervix. So I had a supracervical hysterectomy where you keep the cervix in. So I have to keep monitoring my cervix. So I go in every year to my girlfriend who's Edie that I told you about that has never run an estradiol level. And every time I go in there, she goes down underneath she's in between your legs and she pops up and she goes, "You've got the vagina of a 25-year-old. And that's what I want to hear. And that's what you can achieve. And then you don't have any pain when you make love, and you have less urinary tract infections, and things function a lot better. And we also know little tricks now to even thicken the vaginal wall safely. So you want to have a younger vagina as you age, because that makes so many different things. You are much less prone to prolapse, which is an issue, especially if you've had children. So I don't know. Is that
Well, and
helpful?
incontinence too. I mean,
If you give
no, but
hormones vaginally, you have much less incontinence, because the musculature there is getting support from the local hormones. But it does in some women darken the area. So you can, when you're taking hormones down there, suddenly start to have darker labia, and you might get a little bit of that line, like you get that hormone. What is it called again? The line of pregnancy, tinea.
yeah,
So you can get a
Something
little
like
bit of that because you're putting
Niagara.
more.
It's called
I think
Niagara.
the Niagara's at the neck. I don't think that's. But
You
you
have to
can't.
get do you need a suppository, or can you use oral progesterone and then insert the capsule?
Oh, no, you get a special type that's in a
Oh.
base. It's not an oral. It's in a base, usually like VersaBase that PCCA makes. And you have to be very careful of bases, because so when I moved to Florida, so I was doing really well on VersaBase that I got from Jim Hinseer at Las Colinas Pharmacy.
Oh, I
doing
just
really-
heard him on the podcast too.
He's fantastic. He's
Yeah.
like, he's a resource. You know, compounding pharmacists are the true healers.
Yeah.
It's been an honor to know them. I wouldn't be who I am without them. And I think they're some of the most wonderful human beings I've ever met. I just have so much respect for them. Well, he was doing this wonderful human being doing my hormones. But when I went to Florida, we're using a different guy locally. So I started to use him to see how his formulas would work, because not all hormones are the same. Some people buy more expensive micronized hormones. Some people buy cheaper hormones. Hormones come in all different grades based on different costs. And if don't put out as much money, is that, Anne, do you know this to be true?
oh yeah, there are definitely different qualities of the raw materials that are used.
So that makes a difference. And so for me, I always know if someone's uses PCCA, since I lecture for them, I know they're high quality. There might be other things that are high quality that I just don't know about, but he happened to use, I ordered it in VersaBase and he gave it to me in something called Pearl Cream. And I'd put it, you usually put the cream in a toppy click, it goes into a vaginal plunger and you put the plunger up into you and it should be absorbed within about a half hour. So with this Pearl base that I didn't order, I'd put it in and 4 or 5 hours later, I'd go to the bathroom and a clump of cream would just fall out onto the floor. And I started getting hot flashes at night and not being able to sleep for the first time in years because I wasn't getting hormones. So the base makes such a big difference. The base that I think works best for the vagina, that at least for me and the patients I've worked with so far, and it's always a moving target because new products come out, is VersaBase. And on the skin, they have a product called Versa Anhydrous that's supposed to help release it from the skin more even, because you only apply it on the skin once a day and you're wanting to have coverage for most of the day. So you want a base that helps you have more Zen coverage throughout the day. And sometimes people can be a little allergic to some bases and things.
Yeah.
So there's a play with bases, just so you know. But
I saw online today, because I looked because somebody asked this question. And there are people that are using prometrium capsules vaginally.
well, that's interesting. You know, what we learned from the Women's Health Initiative, the 19-year reanalysis, is we used to put down hormones that weren't exactly bioidentical. So we'd go horse estrogen, you know, that's a terrible form. Well, what we learned is it's not as good as bioidentical, but any hormone is better than none. So even the horse estrogen was better than none. So if a patient comes into me and says, oh, you know, I feel terrible. When I was going through menopause, they gave me 5 years of that horse's estrogen. I feel like I harm myself. And I go, no, you protected yourself. Don't worry, any estrogen is better than none. It's not the same for the progestin, but it is the same with estrogen. And if you do get hormone replacement within 5 years of menopause, and unfortunately, because I had breast cancer, I didn't, there's a part of the brain that makes you susceptible to a stroke. I write about this in Safe Hormone Smart Women. If you go on hormone replacement of any kind of estrogen within 5 years of your menopause, it protects that part of your brain. 30 years down the road, you're less apt to stroke out. So even if someone is uncomfortable with the concept of being on hormones nonstop, if you just have a few years, you get tremendous protection down the road. There was a study I presented in Safe Hormones, Smart Women, where they showed if women were on estrogen just for a few years after menopause, they had much better bones 20 years out. So once again, there's this long-term protection from Mother Nature's hormones that drive our human race, even if you use them for a short period of time. But the bases make a difference. So prometrium is a very poorly micronized, very large sized progesterone. Some women take it and they can handle it, but some women take it and the large lack of micronization of it, they don't do well. So some women can get vertigo from prometrium or have issues, and that it's in peanut oil, and there's some issues with that.
Right.
You know, a study, it's in peanut oil, and a study came out. So every morning in my membership, I wake up and go through the literature, and then I post up a lot, right?
It's like,
and I love doing it with my morning cup of joe. And I've been doing it for decades. And now I have this membership where I share it. So an article came out a few months ago that if you consumed peanuts and you had cancer, there's something in the peanuts that helps initiate metastases of cancer. And they actually had identified the suspect molecule of the mechanism of how that worked. I stopped eating peanut butter right then and there, and I've gone to walnut and pecan butter, etc. But prometrium is in peanut oil, so you're getting a not high quality, not always absorbed progesterone with an oil that isn't necessarily good to have on board all the time. Now, I don't know if that oil contains the constituents that article, in fact, I should go back and read my own post and do a deeper dive on that. But I don't think it's good to take peanut oil in every day. And some women can handle prometrium, some can't. If you don't have money and you handle prometrium, that is an option to put it as a suppository in you. Sometimes we women put probiotic capsules in them or boric acid capsules in them for different things. So that's an option. And it's kind of a creative, inexpensive option. It just, you know, because it's inexpensive, it has these isnesses to it. It's a cheaper, crappier form, honestly, of progesterone, but some women, if that's all they can afford and it makes a difference. So it's always what's the best for you and what can you afford and what works for you. But it's interesting that someone was creative enough to come up with trying that. So part of
exactly.
hormones are creative.
So does anybody else have a question?
Dr. Berkson, can you tell us again the name of the book that you said you wrote that women can read and then hand off to their doctors?
It's called Hormones and Breast Cancer Survivors. It's a little ebook. I think it's $9 or so, $10 or something like that on my website.
Okay.
And basically what I did is I looked through the citations up to that point. There's even more now. I probably need to update it, but it gives you all the citations and the mechanisms of why testosterone is anti-proliferative at the breast. So if you had a high-risk woman that wanted to go on hormones and she's just gotten off, you know, aromatase inhibitors and she's miserable and so forth, the first hormone you would look at, the safest one that has data in peer-reviewed literature for human beings, not just theoretical, is testosterone. That would be the first, but you'd want to give natural aromatase inhibitors. I guess, you know, I don't know. Now we don't know if you really want to inhibit estrogen, but the standard of care has been if you give testosterone and you want it to mainly stay as testosterone, you want to shut down the enzymes that convert it to estrogen. We don't know anymore whether that's a smart thing to do, but those enzymes are called aromatase enzymes, and that's where melatonin comes in. Melatonin is an extraordinary hormone, and it's so all the hormones are a family and they function and dysfunction together. Going back to your very first question with some women being reactive to progesterone or some hormones. So you have to think of hormones as all a family. And that includes melatonin, it includes oxytocin, insulin, all the estrogens, progesterone, DHEA. So DHEA and testosterone are your androgens, your male hormones. And also hormones that we don't know that much about, even hunger hormones and other hormones, and thyroid. So you have a family of hormones. Sometimes if one of them, it's like a family. If a member of your family is ill, everybody feels it. So let's say you're initiating estrogen replacement in a woman and she's not feeling like it's helping her. She feels like it's making her worse. It might be that one of the other family members is off and you have to attend to that to get the right response, because they all function together and they can dysfunction together. So if you have, let's say she's on Synthroid or levothyroxine, she's on T4, she's not converting and her free T3, which ideally is 3 or 3.5, is at 2, she might not get the response from estrogen because thyroid isn't happy. So you might need to give a sustained release compounded T3 to really help her response to estrogen. So keep that in mind. Hormones all work as a family. I didn't mention that when I should have mentioned it in the beginning. If one isn't working, you have to take a look as a checklist at all the other hormones and see how they're doing. That's why we evaluate in an intake things that give us a sense of your adrenal gland health, your thyroid health, your insulin receptor health. That all plays a role in your sex steroid hormone health. The hormone doctors of the future will look at all the hormones. And in men, when they go in, they should have estrone and estradiol measured. We do sometimes give progesterone and estriol to men, because men have all the same hormones we do, but just in different ratios. So was that the answer? Oh, wait, so the book is Hormones for Breast Cancer Survivors. And then you might want to get Safe Hormones, Smart Women, and also get Estrogen Matters by Avram Blooming. I interviewed him for my first book, and I started to do a sequel to that book, and he was so trying to get hormones available for women with breast cancer. That's his new goal that he wants to do. So he's not wanting to focus on bioidentical hormones. So he does come out against bioidentical hormones, and he has 264 women who've had breast cancer, many of them ER positive. He's a cancer doc from Southern California, Avram Blooming, and he's given them Premarin. He's on the board of the company that makes it. So that is the estrogen he uses, but he's done a lot of good in his career. And we have learned that Premarin is better than no estrogen. And he's tracked these women now for 24 years. And there's about 25 studies and a few more than that. And there doesn't seem to be adverse events of giving hormones to women who have breast cancer, even if it's ER positive. And yet we often put them on blockers and make them pretty miserable and age them prematurely. So this is a big bugaboo in the standard of care deal. I wouldn't be who I am today if I hadn't been on hormones, and everybody said you had breast cancer. You can never be on hormones, never. But I didn't think that the literature was supporting that. So it was scary for me. Think of it, 25 years ago, which is 5 years out from my cancer. I had it 30 years ago. I decided to go on hormones based on the research. All my functional doctor friends said, do not do it. You're going to get breast cancer back. And my radiologist, my breast cancer doc, they all said I was going to die. I mean, really, people were so angry at me. And now everyone asks me, how is it that I am who I am at the old age that I am? And really, that's the most common question I get when I talk. And I think it's because I've been on hormones so long, because most people don't have that energy, and that movement and that facility to grab the word, because your brain, the plasticity, that neuroplasticity leans on hormone robustness. So I think the biggest thing that we can do for America today is really edge out that standard of care and replace it with a new one where we appreciate the power of hormones, We understand that they work together as a family. We understand you need nutrition and exercise. We learn that you need to detox the receptors. You need to balance them. So stay tuned for my products, because those are going to be a must, whether you're on replacement or not. And it's based on years of working in this space. But I think that tending your hormones is a main way to keep you out of the nursing home and nursing facilities and aging. And if we had more people on hormones, we would have less people in nursing homes. I just think that is the fact of it. But we're in the dawning age of Aquarius, where this is just starting to happen. And lucky that you have Anne, Dr. Anne, guiding you with all of this, because she's getting dialogues that you could be exposed to help you out to understand it. Because when it's not standard of care, you're on you're on a sticky wicket. And I don't know why there's so much bias. So I lectured in Miami 3 months ago, and Abraham Morgenthaler he has had the same battle with men. And he put up a slide, and his name is Abraham, and my father's name is Abraham, and I love my father so much. So I'm kind of biased toward people who are named Abraham. Makes my heart warm. So I was focused on his talk. I was so lucky I got to hear it. And he had a big slide that he put up, and he said, everything we've learned in med school about testosterone and prostate cancer is almost everything we've learned in med school about testosterone and prostate cancer is wrong. And he's done the research himself. He's not like me, where I just connect the dots of other people's research. Although I've had published original research in peer review. I have done some original, but it's not on hormones. Although I tried to do a huge bioidentical hormone study at Tulane. That's a whole nother story, about 20 years ago. Because I knew this was coming down the road. And he and I reached out to him last Sunday morning, because I had a male patient that I really like in Naples, where I work 1 week a month, and he's on hormones, and he stroked out about 2 weeks ago. And he was in the hospital, and they took his testosterone away because he just had a stroke. And he texted me, can I stay on testosterone? And I didn't really know. I know about women, and we could go into the whole thing. I don't know if we have time to do that with estrogen and women who have genetic tendencies to clot and so forth. But
well, actually, Lindsey, we just got a question in chat about estrogen with a blood clotting history.
Perfect.
Because her doctor says no. So
perfect. Yeah. So I reached out to Abraham because I didn't really know in men. I don't do men as much. I do a few, but and that's in a team practice with docs. So he wrote me right back on a Sunday morning, like 3 seconds. I sent out the email and it came right back, and he went, there is a lot of data accumulating that if a man goes back on testosterone right after he has a stroke, it shortens his recovery. It makes his recovery more robust. And I would have no hesitation to say that he should go right back on his testosterone. So that's from Abraham Morgenthaler. He's the guy that put low T in our understanding of it on the map, but it's not standard of care. So his doctor called me yesterday, and I said, well, I'm not the prescribing doc for that. So you have to call up Dr. Roberts. And we all got on a team call, and we had this call together talking about it. Now the patient got back on hormones today. So with women who have genetics that they tend to clot, like factor V Leiden, it's always been thought that if you have a tendency to clot, estrogens make you clot, so you can't go on estrogens because they're contraindicated. But estrogens make you clot if you take them orally. That's the one problem with the new Bijuve, is it's only oral. Mm-hmm. Oral estrogens pass through the liver, called the first hepatic pass, and then they make metabolites that are prone to clotting. If you take estrogen topically, or you take estrogen vaginally, it does not promote clotting. And there's 4 or 5 articles in the literature that explain the mechanism of this and prove this. So Dr. Pam Smith in the endocrinology module at A4M teaches that right after a stroke, you could give topical and vaginal. Of course, they don't, their way of giving hormones is mostly topical. But the more delivery modes you get comfortable with, the better, because everybody at some point is going to have a problem with one. And sometimes now we're learning a combo is even better. So it's good to be facile at a number of delivery modes. And delivery mode is how you get the hormone in you. So we are now learning that for men, testosterone replacement after stroke helps them get over the stroke better. For women, if you take topical estrogen, it's not worsening even your genes. But the problem is it's not standard of care. And so you need to have disclaimers, and even those disclaimers don't hold up if, God forbid, somebody can get a stroke, because people can always get cancer or stroke at any time for some unknown reason. So that's the problem, is with this cultural mentality that hormones cause stroke and hormones cause breast cancer and hormones cause all these problems. But then they pass out birth control pills for years to women, which is a whole, I mean, none of this, if you look at the bigger picture and back up, it makes kind of craziness. But the standard of care is kind of an issue. So I think you have to have releases that people sign and a little bit of a conversation. If you work with hormones, you might have adverse events, just like if you didn't work with hormones, and you have to be comfortable with that.
Well, and the thing is, you know, you can buy est over the counter. I mean, it's not a very high strength, but it's available. I mean, people can go get what they want, basically.
In America, not in a lot of other countries.
Yeah, in America.
So we're really pretty lucky in that way. Up to now, hopefully, if they don't take our rights away for this. But that's exactly right.
Would you email me the information about the long distance progesterone desensitization? I
use a woman named Virginia Allen. Virginia Allen has been Dr. Wright's nurse for about 45 years. And, you know, he's a Harvard trained doc, and I think he's in about almost his 60th year of practice. He looks like Father Time at the moment, Dr. Wright. And, but he's only a few years older than me. And she's the one to contact. I'll give you her email, and they have forms that you fill out. You can do this long distance testing and desensitization for other things besides hormones. So they have two pages of a form that give you all these different things you can test. It could be grasses, dust, food. I basically use it for hormones, and I check every single hormone off on the list. They also test bases to see who can handle bases better. I haven't used that part of it yet because I like to stick with Versabase, and I think it works for most people. It's a hypoallergenic base, but they do test for bases. And she does the testing long distance. They send tubes to the patient to get saliva collection, and then they use that tube with some kind of Vol energetic machine, and it's been extremely helpful, and I'll be glad to send that along. Okay, that would be great, because then I can share it with the whole group, including people who are not here. And just one other thing. So there's so many questions. And so to Monday night, is that okay if I talk about Monday night? Yeah. So as long as they can access it. So it's for people that aren't a member, it's $25. And there's a link that I can send to Anne. But we got David Brownstein, who's been using hormones for almost 40 years, for an hour, and then his partner. We have David Rosensweet, who started the menopause method, and he was one of my doctors when I had breast cancer 30 years ago. He worked with me to give me nutrients and ozone and things like that way back then. And so he and I have known each other for decades. And then there's Dr. Carol Roberts, who's the medical director at the Naval Center for Functional Medicine, where I work in Florida, who's been doing hormones forever. And she's the one who's 76 and her FSH is 7, so she knows what she's doing. And she's one of the healthiest, vibrant people, and she's still working, going strong, and she's a few years away from 80. You think she looks like she's 64 or something. And then there's me. And we're going to be available for 2 hours to ask a whole bunch of questions and to bounce things around from everybody's got a little different point of view. So it's something for you to think about. It's Monday night at 6 p.m. Central. There's a link if you want to go to it. We just decided to I called these guys up and said, what if we had a panel where people could ask you whatever you wanted them to ask you? And we did it for a bunch of time. So that's what evolved. And it's Monday night Q&A hormone panel with 4 amazing people. I'll say at least 3 amazing people. I'm not going to say that about myself.
You can say that. I'll say it about you.
Okay.
So it's okay for lay people?
Yes, it's for everybody, anybody and everybody.
So if you will email me that link, I
I
will
will.
post that as well. So that and the desensitization information.
Because Dr.
And-
Brownstein, in his office, he uses NAET. So it might be interesting to ask him a little bit more, Steffi, about, were you the one asking about NAET, or Rena was
I
asking
think that was
about
Rena.
So he's been using that in his office for a while. That'd be very interesting to ask him about that and what else he uses it for. And he, of course, has 12 books out on health. His first one was on hormones. And his first experience was he's a Michigan doctor, went to University of Michigan like me. And there's a lot of great docs in Michigan. I don't know, Michigan's really a cool state. And he graduated and was seeing patients, and he felt like all he was doing was handing out pharmaceuticals, and he was very unhappy. And his wife and he are very close. She's a lawyer. And he said, I think I have to quit medicine. It's not what I thought it was going to be at all. So he had a friend that was a chiropractor that had Dr. Wright's first book on hormones and nutrition. I forget the name of the book, but it was like a classic at its time. That's why I did that mentorship with Dr. Wright, because he was like one of the stars to say food and hormones make a big difference. And this was, like almost 45 years ago. So he got that book, and in the book, it talked about the importance of hormones, and that many people are subclinical hypothyroid, and it doesn't show up in the blood. So his father at this time had serious angina, was so ill and gray, and had been through several stints, and was really, they thought, close to dying. So he measured his father's testosterone, and it was in the 100s. So we put him on testosterone, and then he assumed, because his father's hands and feet were really cold, that he had subclinical hypothyroidism. So we put him on a sustained T3 that he'd never really used before. And his father was on many, many meds, and basically homebound, like that woman I told you about in Oklahoma. And within a week or two, his father had no more angina, not on his angina meds. His coloring came back, and his dad went on to live somewhere like 12, 13, 15 years later with a really high quality life with hormones on board. It was hormones and then a little cleaning up of no sugar and processed foods. But it was the hormones that reversed his father's relationship with his heart disease and his ability to be more alive than being closer to death. So that changed David's entire practice and made him respect the role of hormones. It's not just about libido. It's about occupying your body more fully and being more fully alive.
Exactly. Well, I appreciate you sharing all of your wisdom with us today. We have run way over.
Oh, it's almost
been
2
fabulous.
hours. I'm a little hoarse.
So I know, right? But thank you for being here. And, I just appreciate, all that you've shared with us. And I hope that you guys have gotten a lot out of this. And we'll post the recording in the group for you to access, along with the link to Monday's seminar that they're offering.
Is there just something that you feel like you didn't get answered? Should I just take one look at this chat here?
No. We talked about the clotting. We talked about the desensitization.
I have a question.
Go ahead, Susan.
If I may. Well, one is, if I've had an ablation, does that affect the uterine lining reading, that type of thing?
Gosh, I don't know the answer to that. I'd have to find out. That's a great question, and I don't know the answer. Okay. I'm going to reach out to a number of my gynecologist friends. I'm going to talk to Jack Monaco, and I lectured together quite a bit. I'm going to send an email to him and ask him, and then I'll send it to Anne. I don't know the answer.
Okay. And then my other question is, I'm not on it, and I'm in perimenopause right now. So when would you actually start taking these hormones?
Great question. What do I have? Oh, no, I don't think I can't get up. gonna run and get a glass of water.
What do you have, no pants on?
I- Oh God, because I was here working with patients and I wasn't anyway, so I'm not gonna get up and get a glass of water. That's so funny. That is kind of like a bathing suit though. Anyway, so we think of hormone replacement for perimenopause or menopause or andropause, but then there's a whole nother thing going on. And that's that the ground rules for life on planet Earth have changed. And the Earth is encompassed in a layer of pollutants. I write about this in Hormone Deception. And there's pollutants from Zaire in India and that go up into this mini whirlwinds and circle our precious Mother Earth and drop down in your backyard and my front yard, so that our pollution is intermingling on the planet. And much of this pollution acts like hormones and can get into these malleable receptors and cause disruption. So the names of these potentially disrupting pollutants have been called endocrine disruptors or endocrine disrupting compounds, EDCs, endocrine disrupting compounds. So before the mid 1990s, nobody knew anything about this. I happened to bump into an article on Lou Gillet. He was a biologist at the University of Southern Florida, looked like this He-Man. I mean, just this amazing He-Man. And he was hanging out in Lake Apopka in Southern Florida, which was very polluted. And he would capture alligators. This He-Man, he would capture, we have all these pictures of Lou Gillet doing this because I worked with him at Tulane. And his wife is an anthropologist and she did a lot of amazing work. I write about both of them. He unfortunately died a few years ago and his wife Elizabeth felt that it was due to the pollution in Lake Apopka that he hung out in. But he would measure these, he would tie the alligators to surfboards and he would measure the size of their penises compared to alligators that weren't being raised in polluted waters, and their penises were smaller and smaller. They had very little, he took blood samples. They had very little testosterone and a lot of estrogen. And some of them even had ovaries. They were gender bending and getting feminized, even though they were masculine alligators. So that started to be like, oh my God, our hormones are under attack. So I started to delve into this for a book called Hormone Deception. And in a 3-month period, 3 books came out: Our Stolen Future, Hormonal Chaos, and Hormone Deception. They all came out in 2000. And it burst wide open that the animals were the canaries in the mine, but this was happening to us. So the problem is that a pregnant human being now will have a lot of these potentially endocrine disrupting compounds in the amniotic fluid. That's been well described at Cedars-Sinai. They've taken samples of healthy young pregnant moms, and there's all these chemicals kind of similar to Lou Gillet waddling around in Lake Apopka. So we have in our air, food, and water, and in our amniotic fluid, which is of course what the baby's environment is, we have now kryptonite for hormones. We have potentially a planet that's rife with hormone endocrine disrupting compounds. So we are seeing less hormones in teenage girls, in 20-year-old girls. There's papers being presented at ACOG where gynecologists are seeing a trend in some young girls to be starting perimenopause in their 20s. The reason when I interviewed Angela DeRosa the other night, why she got into this is that in med school in her 20s, she was going through perimenopause and then she went to full-blown menopause at 35. So the hardwired biological ages of reproductive milestones, menarche when you first start to menstruate, perimenopause when you're ovulating less, and then menopause, these are all changing. And just a few months of changing these hardwired things, it makes big differences for humanity because they're supposed to be hardwired. So now we're seeing that some girls do better with hormones, that they need them at younger ages than we ever thought possible. Harvard has an observational trial, Harvard, where a lot of young girls exercise a lot now because you're supposed to be skinny. You're supposed to be really a great athlete. You're supposed to be everything in America. Everything. You're supposed to be gorgeous, supposed to be sexy. You're supposed to make money. It's exhausting. It's utterly exhausting to be a woman in America because you're supposed to be the best at everything and look phenomenal and make money and not need a guy. And you know that when Europeans look at us, they can't believe the pressure that American women really are under. So Harvard took some of these young girls that were obsessively exercising or had body dysphoria from 14 years old to 24 years old, and they slapped the one that I don't have on my arm, an estradiol patch on their arm, 14 years old. They kept them on there for a year. And when it was over, they had less anxiety, less body dysphoria, they had better academic performance because they didn't have enough hormones. So one, that's the environment. Two, there's this obsession with being so thin and your fat cells make some hormones. So it's set up where we're now seeing hormone imbalances younger and younger. So I think ideally we need to have our hormones checked once every decade from the time that we're alive. It's changing. If you do give hormone replacement, you need to base it on a person's own hormone. Now, a lot of doctors will wait till someone's 60, they know all the hormones are empty. They'll just give them hormones without testing. One of the people where I practice does that. I like to get a baseline in anybody I work with, and then in a few months later, get another one. Because I want to know, some women will have elevated testosterone, even though everything else is low. So it's always good to check hormones, whichever way you do check them. You can start giving some hormones in perimenopause, but now you have to think that perimenopause is happening earlier and earlier. And the use of birth control pills is vast. There's multiple millions of girls on birth control pills. And what do birth control pills do? But they shut off down your hormones, especially oxytocin. There's replicated papers on girls that are taking birth control pills that don't have as good perception in relationships and communication and handling big decisions, because hormones help your brain do all that. So
well, and they screw up your gut health too.
Exactly. They're endocrine disruptors. So at Tulane, when we were measuring hormones to see which ones were endocrine disruptors, we had two major controls to test, like a plastic or a perfume or something. So the first control was the most powerful endocrine disruptor that's ever been invented, which is diethylstilbestrol. That's like 50 times more powerful than estradiol. So that was one control. And the second control was ethinyl estradiol, the estrogen and birth control pills, because it's an endocrine disruptor. So we now have a culture, and it's well established that men have less and less testosterone levels. So Lou Gillet, while I was at Tulane at the Center for Bioenvironmental Research, Lou Gillet made a presentation to Congress about we need to start testing new chemicals to see if they alter hormones, because this will affect fertility and brain development and things. So he made a lot of these scientists, Tyrone Hayes and Lou Gillet, they made this big, along with Al Gore, he came over and hung out with us, and they tried to raise money to test endocrine disrupting compounds. And Lou is kind of famous for standing up and saying, all the men in this room are only half the man that their grandfathers were, meaning that their testosterone is lower. And he started the research with the alligators in Lake Apopka. So we think of perimenopause as being in your 40s, right? Your late 40s. That's what we usually think. And maybe you look at your hormones and you start giving some, but now you have to keep the awareness that it could be in the 20s. It could be earlier. Or they could have hormone imbalances because they've been on birth control pills so long that they've turned their hormones off, which we know do so many. So there's a lot. I do a whole talk. I haven't done it in a while at the gastroenterology module at A4M of going through the literature, all in the literature of the role of birth control pills and the incidence of inflammatory bowel disease. It's shocking because hormones protect your gut. And when hormones are turned off, you have a much higher incidence of very serious gut issues. So did that answer your question? We're in a changing, so, the dawning of the age of Aquarius, so hormones are coming in. At the same time, hormones are being attacked, and we have less hormones as Homo sapiens than we did before. And everyone worried about gender bending at Tulane. And now we have, what's this new generation has gender fluidity. Is some of that from the hormonal milieu changing. No one knows for sure. These are all, unfolding, kind of like the pandemic is unfolding, we're living in it. But it's always good to test hormones because you never know where you're at. And when they're lower out of balance, you want to help get them back in balance. So you might now start giving hormones at younger ages than we classically
there
thought.
also is so much foundational work that can be done with, diet and cleaning up your environment before you get to the hormone replacement aspect of it. At least in perimenopause, that's mostly who I work with, is the perimenopausal people. But, you start cleaning up some of that stuff and things get quite a bit better.
That's very true. And there's basics. Remember, I started out with the receptor. You have all these nutrients that are transcriptional factors. So in my product, Hormone Balance and Protect, it's got a good level of vitamin A and all those transcriptional factors. Sometimes if you give those and clean up your diet, you start getting your hormones to work better and respond better to the signals. So Anne's right. The first step would be lifestyle and nutrition. And sometimes though, there's replacement at ages you wouldn't have considered.
Yep. I talked to a 33-year-old yesterday who had been in menopause, or she was 36, been in menopause for 3 years.
So what are you going to do for her?
She contacted me because she's not responding to, she's responding badly to the vaginal estrogen they gave her. So I suggested that she talk to her doctor to change the dosage form and a couple of other things to help her sleep. And we're going to reconnect in about 6 weeks. So do they know the cause of, so that's kind of like premature ovarian failure. Do they know her mother and sister experienced the same thing. So no, we didn't get into a whole big discussion about that. But there was a family history of very early menopause.
Well, just little pearls. I did have one woman who went into menopause, premature ovarian failure, about, 33 years old, 34 years old, maybe a little younger. And she hadn't had a child yet. So in my intake now on my blood work, I always now run heavy metals. So blood is going to reflect heavy metal exposure now. Whereas if you do a hair analysis or a provocation, that's what's sequestered, but blood tells it now. And it came out because I work in Naples and people eat so much fish that their blood levels are really high in cadmium, arsenic, lead, and mercury, just really high. And those all sit on the hormone receptors. And if you don't clean them off, you give them hormones and nothing happens. Those are all competitive inhibitors. So when this woman, her lead came out sky high, so much so that the toxicology department called. Long story short, she was Indian and she was getting turmeric from her family sent from India. It's sold by weight. So they were putting lead powder in the turmeric as to make it cost more. So her lead was sky high. And when we chelated her out, she started menstruating again. The lead was occupying. And then the one other thing is there's an article on using oral estriol, giving it 10 milligrams for a month. And it was a very small study of just 12 women, but all women started to ovulate again. And when Ken Korak spoke at the last endocrine, he's the one that discovered the second receptor. He said that that ovulation is run by estriol. He made that statement. And it was interesting. In some women, if you give oral estriol for a short stint, it'll reboot ovulation and menstruation. So that's just a little clinical.
Okay, thank you. Thank you for that. All right, so we are going to wrap this up because it is 3 o'clock and I have not eaten lunch yet and I'm about to starve. Thank you so much for everything. And hopefully we can have you back another time and we will continue the conversation on all things women's health because you are a font of knowledge, that is for sure.
And don't forget about the Monday night panel, because if you have any other questions, but it's always so nice to hear other people. They'll have totally different answers or ways that they deal with things. And you can never have enough ways because you try
Yep.
one way with a patient and it doesn't work, then you want to have backup ideas. So it's always good to hear what other people are doing for things, because there's not one way to do things. And I so
Okay, well,
respect that. Okay.
If you will send me the link, I will be happy to share it. And guys, I will see, gals, I will see you Monday at 4 o'clock for our Q&A. And then you can just go right into their session. Thank you all for being here. I hope you got as much out of it as I did. And